Welcome again to the Cardiovascular Research Foundation. We're now in the third part of this webcast series talking about the Biomimetic DurAVR THV system, studying its clinical impact and restoring native flow. We began by saying that, frankly, we've not paid enough attention to the leaflets, and the leaflets are king. And we now have a new technology that, with a biomimetic design and a monoleaflet concept, that may reduce wall stress by achieving pure laminar flow, perfect flow with an implanted valve compared to a native normal aortic valve. That's great. Well, now we're going to shift gears a little bit and talk about the impact of flow on the myocardium, because it's not just at the valve level that we stress and strain. When there's myocardial dysfunction associated with maladaptive LVH and its consequences, this causes significant clinical outcome issues. So we're going to look more at this concept of LV mass regression and the importance of reversing LVH as part of the treatment goal in patients who have aortic stenosis, and that our long-term achievements really need to be based upon our ability to restore to normal not just the valve itself, but the effects of the valve on the myocardium. So we're going to start by having Brian talk a little bit more about LV mass regression and some of the observations he's made with the earlier partner series.
Yeah, thanks, Marty. I think one of the things we were all taught in medical school was that in the setting of pressure overload, that hypertrophy is compensatory and we think therefore good. And according to Laplace's law, as you increase that wall thickness, you decrease wall stress. And so it was always viewed as something that was normal, physiologic, and good. And while there is an element of physiologic adaptive remodeling to pressure overload, I think we've come to appreciate that it's not all good. And there's definitely a maladaptive component to that, and that maladaptive hypertrophic response is influenced by a number of factors. So we don't see it in all patients. And there's wide variation for a given severity of aortic valve obstruction in terms of how much hypertrophy you actually see. And so this is influenced by things like, age and sex and metabolic milieu, like, diabetes and metabolic syndrome and genetics and afterload, hypertension. And so all of these things combine in ways that we don't really fully appreciate and understand at this point to impact how the heart responds in terms of its hypertrophic remodeling to aortic stenosis.
It's amazing. I had a patient in the office last week with moderate aortic stenosis, considered for some of the trials, but what bothered me the most was he developed LVH in 6 months. And all of a sudden that seemed to be a warning sign to me now, because I'm thinking more about LV hypertrophy, what that means for the ventricle. Maybe this patient isn't so moderate after all. We have to figure out how best to treat him. But is LVH the kind of thing clinicians should be looking for when they're looking about what are other signs and signals that you have for left ventricular mass?
Yeah, I mean, it's been sort of in and out of the guidelines at times. If you look at various iterations of the guidelines and you look at American, European, sometimes LVH has popped up as one of the criteria that might cause you to consider intervening sooner in an asymptomatic patient. And in the partner trial, we did show that severe left ventricular hypertrophy prior to valve replacement was an independent predictor of mortality afterwards out to 5 years. So indeed, certainly at the more pronounced end of the spectrum, severe LVH for sure is associated with worse outcomes.
So I think we should all be much more thoughtful about this. But you've done a lot of data on this with the partner trial. You've done some pretty provocative work. Maybe you could explain that a little bit.
Yeah, the partner trial, I think, offered the first and largest opportunity in a very robust manner with core lab adjudicated echoes consistently done over time for us to really understand how LVH changes over time, regresses. And we made a number of observations. One is that, on average, there is LV mass regression, of course, after valve replacement and out to a year, at least in that study of patients with moderate or severe LVH prior to the procedure, is about 15% at 1 year, and it continued at 2 years and 3 years. But there was a lot of variation, and some people didn't regress at all. And we observed in over 1,400 patients, so this is a robust data set, that regression at 1 year, the amount of regression at 1 year, was independently associated with mortality and rehospitalization between 1 and 5 years. And also observed that of that cohort of patients with moderate or severe LVH, 39% still had severe LVH at 1 year. And that in particular was associated with a marked increase, almost a twofold increase in the adjusted hazard of mortality and rehospitalization. So I think it really solidified that LVH regression is a meaningful surrogate endpoint that has a strong association with subsequent clinical outcomes.
Brian, does this have anything to do with patient-prosthesis mismatch after the implantation?
Yeah, I think studies have been, some studies have pointed to that being something that impact and influences LVH regression. And I think to some extent, probably, taking all the data in totality, there is a role, but in terms of PPM and subsequent regression, and so the valve matters. But there was also a lot that just was unclear. In a very extensive multivariable model, almost nothing was coming out as a smoking gun in terms of what was driving or influencing LVH regression. So frankly, I think we have a lot to learn about it. And some of the things that might be looked at with the DurAVR and laminar flow is something that we never even contemplated before. We never had a way to measure that or think about that. And so I think this is an opportunity to just understand better what underlies LVH regression.
Marty, how are we going to study these non-responder groups? Because I think probably if we would put this all together, probably rehospitalizations were a little more frequent in this group. Once you have a rehospitalization, it markedly increases your mortality and risk for subsequent hospitalization. Marty, how do you think we can study this? I mean, is this something we're going to have to go back and look at echoes and say responders, non-responders, and evaluate that? Or is this going to be so variable patient to patient, it's going to be hard to do?
It's going to be tricky because many of these patients do have other comorbidities. So, response to treating the valve, in the setting of, other associated cardiac and non-cardiac disease can be problematic. So it's not going to be easy. But I think we do have to start with techniques that we're familiar with. And I think echocardiography has been a very good tool. I think the cardiac MR is also a very strong tool that we're underutilizing right now, largely due to unavailability and other factors. But I think in the future, that's going to change. And as that changes, I think we're going to get much more sophisticated in looking at things like myocardial fibrosis, and we're going to be able to measure geometric remodeling in specific ways. And we're going to be able to, I think, come up with paradigms that help us to understand what healthy and unhealthy is as it relates to cardiac function. And that will translate into clinical outcome differences. It's going to be a bit of a journey, but we have to start somewhere. But the place to start is to restore normal flow.
Yeah.
And to have a valve that does that and to really takes the valve that we've now replaced the disease valve with and render it completely normal from a flow situation gives, I think, you the best chance of determining whether or not that impacts some of the other cardiac abnormalities that will ultimately determine what clinical outcomes will be.
Yeah. Brian, how do you think we're going to study this?
Well, I think, more robust phenotyping is going to be useful. We have incorporated biobanks into some of the trials that we've done that I think could give some pathobiological insights. Using more CMR so we get insights into things that we didn't measure before. Laminar flow being one of them, and the implications that might have. Vascular contribution to so valvular contribution to afterload reduction, but also thinking about the interplay with the aorta and the composition of it and the flow, and these are all things that, quite frankly, we don't know a whole lot about, and there's a lot to learn. I think that's one of the things that makes this field exciting. We're 20 plus years into it, and you guys have been part of the journey at the very beginning, and some of us, younger guys, a little less of the journey, but there's still a lot to learn, and I think the thinking that just putting a new valve in fixes aortic stenosis is a bit simplistic. And I think we have an opportunity to, better understand the disease with an implication for an opportunity to, optimize outcomes for our patients.
I mean, Yoshi, we were at the Brigham together, and you had a very, very good surgical team at the Brigham. But I don't know that do you have conversations like this with surgeons? Do you actually, as you're thinking about planning a case, do you go into, I want to do regression? And how are we going to convince the surgical community that this is an important concept?
I think we have the concept that is really built on great hypothesis, right? And there's some early data to prove it, but I do think that we need more data to show to the surgeons that this is really important. We're also very logical. So, if we get the data showing that laminar flow does create a better LV mass regression, leading to better survival that you saw in the partner series, Brian, I think people will be convinced. And I think we're at a stage where we need that data. And I think the DurAVR pivotal trial, the paradigm trial, will be a great opportunity to prove that.
I was just going to say that I'm not worried about convincing the surgeons. The surgeons are pretty smart, and I think that they're going to pick up on some of these things fairly quickly. I'm more worried about convincing the practicing cardiologist that takes care of the mass of patients with aortic stenosis and having them pay more attention to not just the Brown-Wald-Ross curve that was published 55 years ago, but looking at echocardiograms with a different lens, looking at other cardiac imaging techniques, maybe biomarkers, to really have a more integrated patient-specific approach of how to manage aortic stenosis. And it's going to be a process that is different than what is currently done.
It's getting all of us to begin to think that this is not a medical elective procedure, but this is actually an urgent procedure, because I think a lot of the data that certainly came out of the early TAVR was that this watchful waiting approach, sometimes people tipped over and got into trouble before they could get things done. Now, that's a very important concept for people to understand, at least getting prepared. I think we do have to change a little bit about thoughts about the urgency of aortic stenosis and when to be treated. Maybe we could just touch base, Yoshi, just on what we talked about last time with this mass regression. Then we'll go into kind of having you give a couple talks about what's going to happen with the paradigm trial.
Right. So, last time we spoke about the biomimetic design of the valve itself, leading to the laminar flow. And this is actually collective patients from DurAVR patients that's been treated in the past, showing that there was a 22% LV mass regression. And very interestingly, when they were compared to the healthy individuals who did not have aortic stenosis, their LV mass was almost equivalent, meaning that they restored that LV mass to a healthy level. So we're going to study this in the upcoming pivotal trial. It's called a paradigm trial, and it's a very grandiose trial. We're going to try to enroll over 1,000 patients in the all-comers cohort. It will be randomized 50% to DurAVR and 50% to control arm, which is the commercial devices. And 35% of them will be a low-risk cohort. And the primary endpoint will be all-cause mortality, stroke, and cardiovascular rehospitalization. But in addition, we will look at the LV mass regression as a secondary endpoint. So I think that's another exciting data points that people would really want to focus and see. And in addition to that, there will be over 400 patients enrolled in the low-risk cohort after the all-comers. And we will look at the 2-year outcomes. So more to come in that cohort.
It's incredible. And it's good that you're going to put a valve-in-valve in this session 2, to be able to understand the value, because we're all thinking now about lifetime management and what happens with the newer valves when they're used to trace to failed other valves. And so I think it's another very, very important component to this.
Ben?
Marty, maybe you could summarize up what we've really gotten out of these sessions.
Now, this has been very exciting. And first, I want to thank you all for incredible insights. This is the importance of having a heart team because we don't come from exactly the same backgrounds. And by having different perspectives, I think we learn from each other. And I think that the impact of that is truly synergistic. So we really believe that if you've got a patient with sick heart valves, they need to be referred to a heart valve team, because that multidisciplinary insight is crucial. It involves medical cardiology, cardiac imaging, understanding cardiac surgery, structuralists, and it's a commitment to individualized patient-centered therapy. So we're now focused on the subtleties on both assessing the disease and trying to categorize the therapy in ways that would allow us to provide truly improved therapies for our patients by looking upstream before we put the valve in, and then downstream after we put the valve in, to make sure that we provided the best multidisciplinary care for these patients with earlier diagnosis, with sometimes preemptive or earlier therapy even before symptoms, and then making sure that we treat, as you nicely mentioned, with some sense of urgency, those patients that are in a risk strata that really demand that they have valve replacement quickly, and then monitoring these patients to be certain that we've understood to what degree they've recovered, how quickly, and what we can do to provide adjunctive therapies to accelerate that recovery and give them the best possible outcomes. So this is a process, and we're taking several steps forward, and I think that the DurAVR THV represents a differentiated, exciting new element in that process. And the Paradigm trial is a very creative, with many different caveats and subgroups that we've integrated into the trial design very cleverly, that speak to mechanistic issues, but also will address some of the clinical outcome issues that are so important to us. So we're hoping that you will take from this three-part webcast some of the new concepts that we're introducing into our lexicon of how we describe valvular heart disease, some of the new imaging techniques that we think are going to be important, some of the new technologies that may drive the future, again, with the expectation and hope that these new technologies are going to make a difference for our patients.